Hello, and welcome to Anaphylaxis UK's Let's Talk About Allergies podcast, where we provide expert answers to common questions about allergies and anaphylaxis. Our goal is to offer valuable insights on how we can all work together to make life easier and safer for those living with allergies. In today's episode, we're delighted to be joined by Professor Adam Fox, OBE, a leading consultant paediatric allergist at Evelina London Children's Hospital, Professor of Paediatric Allergy at King's College London, and co-founder of London's Allergy Centre of Excellence. Adam is a recognised pioneer in paediatric allergy with a career dedicated to research, clinical innovation, and practical improvements in diagnosing and treating allergic conditions. In this episode, we'll discuss the critical topic of adrenaline use in anaphylaxis, tackling the questions we frequently hear at Anaphylaxis UK. From the fundamental basics, like when, how, and why to administer adrenaline, to the more complex queries, such as the legal considerations involved in giving it to someone else. We also explore exciting new developments on the horizon, getting Adam's expert opinion on EURneffy, the recently approved needle-free adrenaline nasal spray, and what this new option may mean for patients and caregivers.
Until now, people at risk of anaphylaxis have only had one option for emergency treatment. That's adrenaline delivered through an auto-injector like EpiPen or Jext. But recently, MHRA approved a new alternative, EURneffy, a needle-free nasal spray that delivers adrenaline in cases of anaphylaxis. It's a really significant development and understandably one that has sparked a lot of interest. Over the past few weeks, we've had many questions come through on our helpline and social media, so we thought it would be a perfect time to explore the subject in more detail and put those questions to you. Adam, welcome.
Thank you very much for having me on.
So let's start with some of the basics, if you don't mind, Adam. Let's talk a little bit about adrenaline, how it works and how it helps anaphylaxis. Some of the questions we often get as well is, how quick does that adrenaline kick in?
Yeah. So I think it's always really important to understand how and why the medicines that we have work, even for the people that are carrying them. And I think the place to start is what's happening when you have a bad allergic reaction. Now, thankfully, most allergic reactions are mild. Hives, itchiness, maybe a little bit of lip swelling, and you can take antihistamines and that will settle things down. And what's going on here is that your body is releasing histamine in response to the exposure to the allergen. But sometimes these reactions do become more severe and they can progress really quickly. And the things that we really worry about in a severe allergic reaction, so what we describe as anaphylaxis, are symptoms in your breathing or symptoms with your blood circulation. And essentially it boils down to two problems. The first is the effect that having a reaction can have on your breathing is that it can tighten up your airways, making it harder to breathe, and that will cause wheezing and chest tightness. Or the effect it can have on your circulation, which is that it causes the blood vessels to relax a little bit, which widens them and drops your blood pressure. And that's dangerous because it means you can't get enough blood to the things that really need it, like your brain and the rest of your heart, for example. So helpfully, what adrenaline does very, very effectively is it reverses those two things specifically. The action it has on your airways is it forces them open, and the action that it has on your blood vessels is it tightens them up, what we call vasoconstriction, and that essentially puts up your blood pressure. Now, there's a load of other sort of peripheral things that will do, like increase your heart rate, which means that more blood gets pumped around the body more efficiently. But it's those two sort of key things, forcing your airways open, bringing up your blood pressure, that are the really important things. And there's two other really important things to know about adrenaline. The first is that it works best given as quickly as possible. And that's why we have people carrying adrenaline around with them, because it's worth having it early, because that means you get much better outcomes. It sorts your reaction out really quickly. And the other really, really important thing to know is that given through that muscle route, injected into the muscle, it's really, really safe. And that means that you can say confidently to people, if you're not sure if your reaction's bad enough, just give it. Because there's no consequence that you have to worry about other than you're going to need to go to the pharmacy and get a replacement for it. There's no consequence to giving it if it wasn't really necessary. So we always say to patients, if you're not sure whether your reaction's bad enough, just give it. Or indeed, you could say, well, when you're starting to think, is this bad enough to need adrenaline, is probably the right time to start using it.
Thanks, Adam. And do you have a rough estimate of how many of these reactions actually might turn into anaphylaxis or result in these
Yeah,
airway, breathing, and
yeah,
circulation
yeah.
issues.
So it's really tricky to put an exact figure on how likely is it that I'm going to have a bad reaction as opposed to a mild reaction. And in reality, and this is why food allergy, to be honest, is hard, is it's really unpredictable. So how bad a reaction might be will depend on things like how much the food you eat, your state of health at the time, whether you've recently done exercise, whether you've had any alcohol. If it's an allergy to drugs, for example, you're more likely to get a bad reaction if it's an injected medicine as opposed to one that you take by mouth. So there's a load of factors, and even when you take those into account, how bad it is still very unpredictable.
Mm.
So you can sort of step back and look at populations and say, well, okay, if I get 100 peanut allergic infants and give them all peanut, how many of them are likely to have a bad reaction? And it's not many. It's going to be maybe 4 or 5 of them. Whereas if you did the same to a load of teenagers, it's going to be a higher number. It might be 10 or 15%. But to be honest, the numbers are a little bit irrelevant. The truth is that it might happen. And so
Hmm.
it always makes sense that if you're at risk of having a severe reaction, you know how to identify it and you know how to treat it so that you're prepared. And by being prepared, knowing how to use your adrenaline auto-injector, having access to it all the time, and getting on with it at the appropriate time just makes you a lot safer.
Mm. We do hear that some people say, well, I've never had anaphylaxis and I've had the allergy for years, so I don't carry my pens anymore because I've never had anaphylaxis. But as you said, you just never know because of all the other cofactors that are involved when you might have
What,
a serious reaction.
yeah. One of the things I hear loads in clinic, and I do my best to pick patients up on this when they say it, is they'll often say, well, I've got a mild nut
Mm.
allergy, or I've got a mild this allergy. And I would say, you haven't necessarily got a mild nut allergy. What you mean is that you've got a nut allergy and your previous reactions have been mild. And it's subtly but importantly different, because what it means is that subsequently in the future, you could still have a severe reaction. Similarly, you'll never hear two allergy doctors when they're talking to each other referring to a patient as anaphylactic to peanut. And I hear that a lot in clinic. People say my child is anaphylactic to. What they mean is they've got a peanut allergy and in the past they have had an anaphylaxis. In fact, they don't always mean that. Sometimes what they mean is my child's got a peanut allergy and their allergy test was really big and somebody has told me that that means they're going to have anaphylaxis, which it doesn't mean at all because the size of your bump on a test is not a measure of severity. When allergy doctors are talking to each other, they'll say somebody has a whatever allergy, and in the past they have had or they have a history of anaphylaxis, and that does mean that that person is more likely to have another bad reaction in the future. But it doesn't mean that they will do. Subsequent reactions might be mild, in the same way as somebody whose previous reactions have been mild might then go on and have a severe reaction. So it's really frustrating that you can't do what everybody wants us to be able to do as allergy doctors, which is say, okay, you guys are high risk, that 5% of patients. So we're going to really focus on you and make sure that you are all over this and are really, really careful. And the rest of you, the other 95%, yeah, you're not going to have a bad reaction. So don't worry too much and, take your EpiPens if you remember, but don't worry, worry so much. We just can't do that. For the
Mm.
overwhelming majority of patients, we have to say, look, you have an allergy, and unfortunately, there is an unpredictable, albeit small, risk of you having a severe reaction in the future.
And what about people with asthma? And how can you, or how can they then decide whether adrenaline is required if their breathing becomes difficult?
Well, if you go back a few years in the olden days, severe asthmatics, so people with what we would refer to as brittle asthma, so asthma that can sort of kick off, very quickly at any time, would carry adrenaline because it's a very good treatment for sudden tightening of your airways. It will do the job even if it's asthma. But people often say, well, how do I know whether my child's having an allergic reaction or they're having an asthma attack? And it comes down to context. So usually with an asthma attack, there'll be, maybe a little bit of background. They might have got a runny nose and a cold or slightly worsening symptoms over a period of time that then, quite precipitously get quite a bit worse. And that's much more likely to be asthma. And that's distinct to the scenario where a child with a known food allergy is eating something and then gets red around the mouth, and then that suddenly escalates and involves difficulty in breathing. So you've got to use context. But sometimes, even with the context that you've got in front of you, it's a little bit tricky. And frustratingly, allergic reactions can happen without obvious hives and swelling and itchiness, and only present with just severe breathing difficulties. And if you think there's a chance that it could be related to allergy and you carry adrenaline, then it's absolutely safe to use it. And it will help actually whether it was because of an asthma attack or whether it was because of an allergic reaction. But either way, call for help. Make sure that somebody who is comfortable dealing with this is on their way. Use your adrenaline, and if things are not clearly better 5 minutes later, use it again. And as I mentioned, if it wasn't allergy or if it didn't turn out to be asthma either, you're not going to have done any harm.
So we often hear uncertainty around who can actually give adrenaline in an emergency. So, for example, do you need the person's consent? People ask a lot, or a parent's consent. If it's a child at school, does a teacher need parents' consent? And Simon and I were actually at a university earlier this year where they had, where a student had said they'd been told that they aren't allowed to administer adrenaline without someone's approval, which is quite concerning. So, Adam, do you mind just clearing this up for people listening? In a real life anaphylaxis situation, can adrenaline be given by anyone to anyone, or does it legally need authorization from a parent or a healthcare professional?
So I think there's a moral question and a legal question there. I'm probably better qualified to give advice on the moral side than the legal side, but in my mind, I don't think there are really any exclusions here. So, for example, specifically, and there's now guidance from the MHRA, the medical regulator, about this. For example, in the school setting, because when we had that real victory in 2017, we were able to get these spare pens in schools. So it meant that schools could have generic pens for anybody that was having an allergic reaction. The understanding is that that was exclusively for people who had a diagnosed allergy, who had had parental consent that their child could be administered this spare pen if for some reason that child's own pen wasn't available. And very quickly, of course, the obvious questions came up. Well, some kids have their first ever allergic reaction. They find out they're allergic by something that happens at school. And if they have anaphylaxis, are we really saying that the school can't use their spare pen on that? Or what if a child from another school's visiting or a member of staff has a bad allergic reaction? They don't have these signed emergency plans in place. Can you use it on them? And the answer from the MHRA was clarified, and it's clearly yes, you can. And I would argue that you have a bit of a moral obligation. There was I obviously won't mention names, but there was an inquest I was involved in as the expert witness, and there was a scenario where a child was having a severe allergic reaction. They, as it happens, their own adrenaline pens that were kept in the school office had gone out of date, and there were other children's pens that were in date. And there was a reticence to use other children's pens because they were saying, well, they hadn't been prescribed for them. And the MHRA will come back and say, no, you cannot use the medicine that's prescribed for somebody else on a different person. And the analogy I raised there is that's a little bit like saying a kid has come into your nurse's office at school and they're on fire, and everybody's got a bucket of water with their name on it. And it turns out that his bucket of water is empty because it's run out. Are you really going to not treat that child that you can see is having a severe allergic reaction with the bucket of water with somebody else's name on it? Because that child might run in 5 minutes later also on fire and you don't want to have used it. You have to use judgment there. And for me, I think it's a pretty straightforward call. Similarly, you hear horrible stories about people who have taken themselves or their child with having anaphylaxis into a pharmacy and said, we don't have EpiPens or our Jext with us. Can we use yours? And the pharmacist will say no, because somebody needs to prescribe it. It's a prescription only medicine. And actually, if you look for legal precedent here, and I'm not a lawyer, so I think I have to put a disclaimer. I'm not giving anybody legal advice, but my understanding is very much that under sort of the Good Samaritan principle, there has never been a precedent for somebody in good faith trying to treat somebody to save their life, doing anything really, having a legal consequence after. So, whilst I think, we always need sort of, the lawyers to give us, the definitive answer. For me, if you've got somebody with anaphylaxis and you've got adrenaline, you need to be using it.
Sorry, I just wanted to jump back quickly to just talk about symptoms again. And I just wanted to ask where antihistamines come into the symptoms of allergies and anaphylaxis, just because I really want to get clear in this podcast, when you absolutely need to be using your adrenaline. Because again, people, and I'm sure you hear this all the time, that people say, oh, I took an antihistamine because I had mild symptoms. And as we spoke about earlier with the people with asthma who might have, a slight wheeze regularly. So I was just wondering, when is it that you absolutely need to use that adrenaline? And when is it that you can have an antihistamine?
So When I was training, there was a doctor I worked with who had a poster over his desk that said, Piriton helps hives, adrenaline saves lives. And I think that's a really good message. I think there's a lot of misconception about the role of antihistamines. So I think people imagine that when they're having allergic reaction and they've got those first signs, the itchiness and the hives and swelling and things, and that they use antihistamine, they believe that they are stopping the progression of that reaction to a more significant one. They're not. They're just giving themselves symptomatic relief for the itchiness that they're suffering from. If that reaction is going to progress, it's going to progress regardless of whether you've given antihistamine or not. It simply isn't a potent enough medicine to interfere with the natural course of things. So if you had a reaction that got better with antihistamine, had you not have given antihistamine, it still would have got better, but you would have just been, more itchy than you were by having taken it. So it's for those milder reactions. And if you have or your child has an allergy, they absolutely should have an allergy action plan which clarifies all of this. They're available ideally from your doctor, from your GP or your specialist, or you can download them off the British Society for Allergy and Clinical Immunology website. But anybody who has an allergy should have an action plan, and that has all of this on it for clarification. And it's very focused on identifying symptoms and being clear that essentially what you need to do if you're having a reaction is make a relatively quick decision. Are you having a mild reaction? It's just hives, itchiness, swelling, nothing above and beyond that. In which case, take antihistamines, keep an eye.
Mhm.
Or are you having a significant reaction? And the signs of that we often break down into sort of ABC, airway, breathing, circulation. So essentially, is your breathing or anything to do with your airway involved? Is there a persistent cough? Not a single cough, because that can happen for any number of reasons, but a cough that is clearly recurrent and wasn't there before. Are you finding it difficult to catch your breath? Is your chest tight? Is there any suggestion of wheeziness? Do you feel that your throat is closing up? Anything that involves that breathing system that, feels like that's out the ordinary, that is a warning sign. That's a flag saying this sounds like it could be anaphylaxis. So get on and give adrenaline. Or in your circulation. So essentially your blood pressure. So how that's going to show itself is feeling dizzy, lightheaded, confused, or more obvious collapse. That's also a big red flag. That means get on with it. Now, just to confuse things a little bit more, in other countries, so in the US, for example, they'll define anaphylaxis a little bit differently, and they'll talk about systems in more symptoms in more than one system. And there might be a sort of little bit of a difference in how they treat tummy pain. My advice with things like significant tummy pain as a symptom would be that if it's because of something you've eaten, if you're otherwise absolutely fine, you can sort of take a view for a little bit, which way is this going? Whereas if it's an allergic reaction to something you've been injected with or stung by, then tummy pain is much more significant a symptom because you haven't just got the food in your tummy called, releasing histamine. So I would treat that more as a symptom of anaphylaxis. But as always, if you're not sure, if you just don't like the way things are going, you don't like the look of the patient, you feel that, they're unwell, you just don't feel right, got that sense of what we refer to as impending doom, and you're just not sure whether it's bad enough, just use adrenaline, just get on with it, don't hold back. So, if you're having to think really hard, is this bad enough? Just use it. So, symptoms involving your breathing, symptoms involving your circulation, definitely get on and use it. Just overall not liking the way things are, feeling that actually this, you feel unwell, your child really looks unwell, and you're not sure, give the adrenaline, call for help, and if things aren't clearly getting better 5 minutes later, give the adrenaline again.
What sort of reluctance do you hear then, Adam, about using adrenaline? And what are the myths around there that put people off and still frightened? Clearly, with auto-injectors like EpiPens and Jext, there's the needle associated with it. But adrenaline itself, surely is a naturally occurring chemical in the body, completely safe. You're saying that we should administer it as soon as possible, but nonetheless, people are still nervous about it.
Yeah, it's a great question. And I think about this a lot and understand it. And I don't think there's a single reason for everybody. I think there's three reasons that in my mind do come up reasonably regularly. So the first is sort of the more obvious one. It's a needle and people don't like using needles. For me, I think the one that is also really important is that it requires you to accept that something really bad is happening and deal with it straight away. And I think all of us, well, most of us, our sort of natural tendency is to think, well, maybe this will just get better if we do nothing. I think we do that in a lot of areas of life, don't we? It's easier to not get involved. And actually, we know from experience that often whatever it was just goes away. But it's that sort of having to sort of accept something really bad, is now in progress, and I need to take action, and I can't be in denial here. I have to do something about it, and that's quite hard. And then the third thing, which I'm not sure how big a deal this is there were stories, I've not heard them so much for a long time. There were stories of bad things happening because of adrenaline, and they were nothing to do with intramuscular adrenaline in the way that we would use it with anaphylaxis. There were some awful stories of inappropriate use of intravenous adrenaline causing bad things that happen in a hospital setting, because of course you can only give something intravenously by putting a drip in, and there's no risk of that with intramuscular adrenaline. The problem is if the adrenaline went directly into your vein, then yes, it can have a very, very nasty effect and cause problems with your heart and things. But that could only happen in a sort of medical setting where somebody's put a drip in and injected inappropriately the wrong amount or too much, or when they didn't need to adrenaline. That's just not something we need to worry about. So in a way, I probably shouldn't even mention the story because it's just sort of giving it life again. Intramuscular adrenaline, which is the only way you can give it with a Jext or an EpiPen, is extremely safe. And the only time there's sort of any sort of caution would be in somebody who's got, for example, pre-existing heart disease. But the line is very clear that, if you're in a life-threatening situation of anaphylaxis, you still give intramuscular adrenaline. But there'll be some patients, some older patients with allergies. This is not really relevant hugely in pediatric practice because these things would be so rare. But people who have got severe cardiovascular disease where their doctor might say, look, there's a small chance that giving you intramuscular adrenaline might exacerbate your existing heart problem. So, make sure you only use it if you have to. And that person would know that because they'd have discussed that with their doctor. But, really, you just have to take the view that when you've got a life-threatening situation, you just have to treat what's in front of you, and use adrenaline if it's available to you.
We may touch on later about people not necessarily knowing all the time how to use their own adrenaline pen, but very often in that heat of the moment and a very distressing situation, it sometimes is another person that may need to administer it. Might be a parent, a friend, or whoever might be accompanying the person having that severe reaction. And it always astounds me how, people might be familiar with how a Jext or an EpiPen look. They've seen them around, but they don't know where they go. And, you ask people,
Yeah.
well, where did you put this? So
Yeah. There was sadly that scene in Pulp Fiction, the movie, where the for dramatic effect, the adrenaline injector was plunged into the sternum in the front of the chest. And of course that's just not the reality of how it's used at all. And unfortunately that's what many people imagine. And then remarkably, I'll have patients who will say, well, you've given me the allergy action plan, so I'll read it when my child has a bad reaction. And of course, when your child is having anaphylaxis in front of you, it's not a great time to start learning new skills. So it's so important that people have practiced. You can get devices either from your doctor or from the online from the manufacturers. You can get the training devices. So just having tried it a few times and trying it, and revising that regularly, really, really helpful so that when it's needed, you know exactly what you're doing. And we often recommend that when your pens go out of date, rather than just throwing them away, have a practice go on an orange. That's what people traditionally do. I'm not sure what's special about an orange, but just using it so that you get that feel of what it feels like when it's given and you've done it before. Because we all do better with experiential learning rather than just seeing something or being told something. So actually having used one is always really, really helpful.
and does it really matter that the adrenaline the pen goes in the thigh? Does it matter that it's in the same thigh?
There's a bit of history here. So traditionally, this was never really sort of, raised. It's we know that about 10 to 20% of people who use their first shot of adrenaline won't get complete resolution within the 5 minutes, and so will need their second one. And whilst the overwhelming majority of the times the ambulance will be there in order to administer the second one, it won't always, but you can't rely on it. So hence we have people carrying two. It's not because I think, as most people imagine, that there's a good chance that the first one will misfire or won't work properly, or they're very, very reliable devices, but you can give it properly, appropriately, and it just isn't enough, and so you might need a second one. So this issue came up of, well, is it appropriate to give it in the same thigh or does it need to be the second thigh? And this actually came up specifically in an inquest. And the expert witness at the time had said, well, maybe we'd have got a different outcome if it would have been given in the other thigh rather than the same thigh. But I think on reflection, whilst superficially that feels like sensible advice, the reality of it is that the effect that you get when you put adrenaline into the muscle is, as I mentioned earlier, one of the important things that it does is it tightens up your blood vessels, and that, of course, if you've injected an area with adrenaline, the blood supply won't be as good in that area because you've tightened up the blood vessels, and that means that if you then put another adrenaline injection in there, maybe it won't circulate around the body as quickly because it's not getting quite as good a blood supply. But in reality, it would require you to give the second shot in an identical position to the first one, which is impossible pretty much to do because they're tiny needles and you just wouldn't, even if you were trying, be able to get it in exactly the same spot. We also know that the studies that have looked at how effectively adrenaline is taken up and distributed in the body have generally used the same thigh to give that second injection and not shown that it's a problem. So there's actually no evidence that that's an issue. I think for me, because this has sort of got out there, what I've found is that when, for example, on social media, I've talked about using your adrenaline pens, my priority has always been keeping things as simple as possible, which is, i.e., as little things to remember. So for me, the important thing is give your adrenaline as soon as you think you might need it and give a second shot 5 minutes later. Don't complicate it by adding in the issue of, but it needs to be in a different thigh, especially when there's no evidence to support that. And just to be absolutely clear, our national guidelines, which are very, very, very carefully evidence-based, do not recommend the need for you to use a different thigh. They've acknowledged that there's a concern has been raised, but said there is no evidence to support it, so they don't advise using a different thigh. What I've found when I've talked about that, I get a load of responses saying, this guy doesn't know what he's talking about. This advice is dangerous. He's not telling you that you have to use the other thigh. So I've sort of taken a
Oh,
view
do we? Don't worry. I think
that
we do.
that we will better just say use the other thigh because my fear is that somebody will think, oh, wait a minute, I'm not going to pay attention to this advice because all these people are saying, well, it's not the right advice. So can I believe anything he's saying? And hence it's a pragmatic, and we could talk about this for a long time about what the rights and wrongs of it. But so I'll often just say, ideally, give it in the other thigh. But I'm saying it through gritted teeth because I'm adding another instruction, another complication that I don't believe is actually making any difference to outcomes. And if you challenge people on saying, well, why do you so vehemently, passionately say, you've got to tell me, where does this come from? It's just one guy in one inquest coming up with well, maybe the reason things didn't go as well as they should was because of this. But actually, when you just passionately just look at the breadth of the evidence, there isn't really anything to support it. And that's why it's not in the guidelines.
I think so, one
But
thing I was just
no,
going
go
to
on.
say, I think that when I've used trainee pens to practice or to show people, one thing I often think is that someone would feel much more confident using their dominant hand to use the adrenaline pen, or I certainly
Yeah.
did. I would always go to my dominant hand to put it in my right leg because that would feel more comfortable to me to do. So I guess it just also depends on how confident you are in using it and just whichever leg you're going to be able to use to get the adrenaline in as quickly as possible.
Yeah. And I think the other thing worth mentioning is that the other thing that's changed in the guidance over time is that once you've acknowledged that it's a serious reaction and you're going to treat it with adrenaline, then antihistamines have completely disappeared from that treatment equation, from the treatment algorithm, because they were also a distraction that aren't going to make a meaningful difference to the outcome. People will start, they'd give the adrenaline, they'll say, quick, we've got to find some antihistamines, and it's really important that we get some antihistamines, when actually it's not. And what will make that patient better is adrenaline every 5 minutes until they're clearly better. And if you're distracted by the antihistamines, if you're distracted by the need to give the next pen in a different place and whatever that requires you to then do and use the hand that you're not comfortable with, etc., it's all distraction. The important stuff is just getting the adrenaline in the best place it is to get it every 5 minutes. Everything else is secondary. And so I think it's good news that trying to keep that guidance as tight as possible, as simple as possible, with as little on it as possible, means that you've got a better chance of those things happening.
So, Adam, this new device, Neffy, How does it work? What's different about it?
So, you know, it's a little bit like the buses. You have one option only for managing anaphylaxis in the community for decades. And then after lots of talking about it, suddenly we've got Neffy coming out, which is, I think, really good news as an additional option. And all being well, in the not too distant future, we'll also have sublingual adrenaline. So adrenaline that goes it looks like a little postage stamp goes under your tongue. But essentially, this is the same medicine. It's adrenaline, but it's squirted up your nose as a way of getting it into your system, as opposed to being injected. Now, superficially, that looks like everybody throw away your EpiPens and Jext, and everybody should be having Neffys. But it really requires a little bit more thought than that, because for me, this is great news because it expands our options, and it's always good to have different options. But I have no doubt that within my practice, there'll be some patients where the right thing for them to do will be to continue carrying their adrenaline pens. For others, Neffy will be a better solution. And I suspect there'll even be some scenarios where they're carrying both. But it's always good to have a little bit of choice. But what the regulator has said is that they are comfortable that in healthy individuals, the amount of adrenaline that gets into your system and how quickly it gets into your system is broadly equivalent, whether it's squirted up your nose or given as an intramuscular injection. And so consequently, we can use these nasal devices. And you know, if you're a first responder, you'll know very well about Narcan. So Narcan is what we give for heroin overdoses. And so lots of ambulance staff and police in places will carry them because they find people who have had overdoses on the street. And they used to be injections and now they're nasal. And that's been a real success story. So really, really good that we've got this additional option. And for me, the obvious patients who are going to benefit are the ones who can tell me, you know, they'll say to me, it's all very well you prescribing me these pens with needles in. I'm so frightened of needles, even if I know I'm having a severe reaction, I'm very unlikely to use it because I'm just terrified by it. And we've got other families where they'll say, do you know what? We do hold back. There's times where we think on reflection afterwards, we probably should have used the pen, but we know that because of this reticence, this sense that it's a nuclear option, giving the injection, we're not giving it as quickly as possible. So there is a suggestion from the data about the uptake of adrenaline that maybe it's not quite as fast when it's squirted up your nose than when it's given as a shot into your leg. But there's a very reasonable argument that says, well, that, you know, if it takes a minute or two longer, but you give it 3 minutes earlier because you're much less concerned about squirting something up your nose than you are about giving an injection, then overall you'll end up with adrenaline earlier than you otherwise would have got it. So this is a better solution.
Mm.
I think for me, the only reservation about something like Neffy, and this is something that the manufacturers can't do anything about, it's new. So we know with adrenaline auto-injectors, they have a lot of history. They have been around a long time. They work very well. They are fit for purpose. They're a very effective treatment. Whereas with the Neffys, they've only been around for, you know, in the US, they've been licensed for about a year. So it's hard to sort of look somebody in the eye and say there's definitely not going to turn out to be a problem with this. And at this time, we won't be saying, actually, these don't work as quickly or as effectively in some way. So we need to be careful. So for me, you know, in a way, it's nice, isn't it, when it comes out in another country first, you get that post-marketing sort of experience in somewhere else that you're able to then draw from. And, you know, I've not heard anything that worries me from the US now that it's been out there. But remember that only a tiny proportion of these devices ever get used because most people don't need them. But we have heard, for example, reports that some people complain of pain up their nose even for the whole day after using it. But then you'll get people who complain of pain in their leg after they've used an adrenaline pen. We get very occasional reports, I've heard once or twice, this is entirely anecdotal, of people saying they've used Neffys and they just don't feel they've worked as quickly as their previous experience with adrenaline pens would have treated their reactions. But of course, that's really hard to say that because this isn't a randomized controlled trial where you've given half of them Neffys and half of them EpiPens. You'd have to an enormous number of kids before you can say, actually, really, this works faster than this. So I think for me, it's really, let's, you know, great. It's a new option. Let's discuss this individually with our patients. For the patients where they're very clear that using a needle has been a caused hesitation, that's the term we use, hesitation in treatment, then yes, Neffy is a very sensible, you know, option. But I've got a lot of patients who are absolutely fine using their EpiPens, don't hesitate using them. They're absolutely fine with the fact that it's needles. I wouldn't change them because they've got a medicine that has got, huge experience of working very well, and there's no other additional benefit unless they say, well, actually, I'm not carrying them because they're too big or they're continually out of date because I'm not very good at keeping on top of it. Because we know that Neffy is smaller and it has got a longer shelf life. And although I think the manufacturers are saying it's 2 to 3 years, I would always say let's wait and see what that looks like in practice. Because the adrenaline auto-injectors will typically say they've got a minimum of 12 to 18 months shelf life, but actually many people complain that they went to the pharmacy and when they walked out and checked the data, it had 6 months on it. So it's one thing what the expiry date is once it leaves the factory. It comes down to what's their supply chain like, as into in reality, what's the expiry date really like. So, and we're not going to know that until it's distributed and it's available. So I'm not going to be sort of standing at the door on whatever date in September when this comes out, waiting to change all of my patients across. I'll be looking to have a conversation with all of my patients who carry adrenaline as to what is the right device for them individually. And I think there's going to be a load of different scenarios.
And what about those people who aren't seeing an allergy consultant anymore? So perhaps adults who have had allergies for a long time and they've carried adrenaline auto-injectors for a long time. If they are now thinking, I'd love to get Neffy because one, I don't enjoy bringing my auto-injectors out with me, or I leave them at home a lot because they're too big. I worry about them in the car in the summer. I worry, about the practical challenges of using my adrenaline injectors, but also I'm worried about using a needle. For those people who are not being seen by consultants, are they going to be able to go to their GP to say, I have a phobia of needles. I'm very worried to use my adrenaline pen. I'd like to get Neffy. Is that going to be a possibility for them, or would it need a review by an allergy consultant?
I would have hoped not. I mean, it is something. I mean, you could argue this is no different to, new statins when they come out, or new blood pressure medicines. Things change and evolve all the time, and that will be picked up with a GP who is prescribing them to, be aware that there's new options. And I think there's a piece here, probably for both the British Society for Allergy and Clinical Immunology, around awareness amongst GPs that these options were available. And certainly for me, the highlight of that campaign would be, do you have a patient who's at risk who just doesn't carry their EpiPens because of the needle? You need to know that there's this new option available. But likewise, there's, I suspect the manufacturers, and I think it's probably helpful that the people that make or the people that are distributing Neffy also distribute Jext. So they haven't really got the same skin in the game of moving everybody from a different company's treatment onto theirs. They'll sell their products whichever one they're on. I think that's a much healthier arrangement. That I suspect they would also be engaging with primary care in order to sort of make people aware that there are other options available. And it's hard to predict how NHS uptake is going to be. I think people imagine that, a new medicine comes out, it gets approval, and then suddenly everyone can get it anywhere, and it just doesn't work like that. The NHS is a monumentally enormous organisation that works in deeply mysterious ways. And I suspect what will happen is that different parts of the country will be quicker off the mark in terms of getting this onto their formulary. And it will be in some hospital formularies, of course, the big specialist allergy services who know that they've got a problem that this solves will want to very quickly get this onto the books. But the primary care setup might not have any, don't quite have the same incentive to do this. So it might take them much longer. They'll need more of a push, and it might take some areas much longer than others. So again, only time will tell what the availability of this looks like across the NHS. And I hope very much that it is widely available and that there's good guidance that comes out from national organisations that ensure that patients and GPs are in a good place to make sensible decisions together.
So it might take a while, and I guess for people listening, if this is something that they would like to consider, then perhaps they just go to the GP and they can speak directly with their GP to find out when that might be available for them.
That would certainly be the right place to start. My suspicion is they'll get a blank look back about what's an Effie, and I didn't even know that that was a thing. But it's a great way of raising awareness amongst the GP, and the more GPs that are being asked about this, the more they're going to filter down to their prescribing committees. There's this thing available, and a lot of my patients want it, and I'm very much hoping it won't have a cost implication. It will be priced, sympathetically at the same price, and hopefully there'll also be a good look at it from prescribing committees, because if it's got a longer expiry date, they might say, look, this is a great way of reducing the amount of resource required to support people with all of these by switching them across where it's appropriate, not because it's cheaper, but because it's the right thing for them. And it's also cheaper, and that can also be a really good lever for certainly in primary care for the powers that be to look at this in a helpful way.
And presumably an option for schools as well to get on prescription in the same ways that they currently do for a Jext or an EpiPen, then they have the spare pens in school.
Yeah, absolutely. So, I mean, I think it's, really important that the schools who are providing that, that sort of fail safe, that second line, if the individual's devices aren't available, that they've got the options that are consistent with what, that individual's been prescribed and what's most useful for the situation, for sure.
And there are certain groups that perhaps it might not be the best option for people with certain allergies. So if you, for example, had venom allergy, or would Neffy be used the same as adrenaline injectors are used for any type of anaphylaxis?
Yeah, I think so. I mean, again, it comes down to the individual, individual situation. So many of our patients who have allergies to one thing will have other allergic related issues, and commonly, certainly in older patients, it will be rhinitis, and if they've got really bad hay fever or bad chronic rhinitis, they're worried that, well, something won't get absorbed up my nose very well. Well, the studies so far don't suggest that that's a problem, and that the patients included in these studies have included those who have got rhinitis. So I don't think that's necessarily an issue. But for example, venom rightly has a bad reputation as being an allergy that can progress very, very fast. And I would say, well, unless you're really telling me that you're not going to use your adrenaline auto-injector because of your fear of needles, I would say stick with the needle, because there's that little bit of evidence that it might work a little bit quicker, and that's really the priority here. Again, individual circumstances. So there's a lot of exciting developments in this area. I mean, we know at the moment that the plan is in September 2025 we should see Neffy for the older kids coming out. So it's the 2 mg dose that's for basically 30 kilos and above. So people who were previously carrying the adult EpiPens or Jext, the 0.3 milligrams. There is a pipeline that means that we are expecting early next year, and I can't see why there would be any major delay in this. That the 1 mg dose, that's the one that's equivalent to the 0.15, so the EpiPen Junior or the lower dose of Jext, would come out. So there'll be more availability. What's hard to predict is how quickly it becomes available on the NHS through different clinics in different parts of the country. It will be, that's just a matter of waiting and watching and seeing how that gets picked up. What you'll find is that it will be available very quickly for private prescription if you have access for that, because there's none of the other things that need to happen in order to go through an service. In terms of sort of the sublingual adrenaline, I think that's a really exciting possibility as well. The pipeline isn't too far behind, and they're talking about an FDA approval in the US, which will happen first likely in 2026. But how quickly that then comes to Europe or to the UK depends on the company that make it. If they're a company whose priority is sort of global distribution, you'd like to think it would be for the same reasons that Neffy felt the need that, they could see there was a market here, then they'll be quick off the mark. Or if they're a company that are entirely US focused, then want to see how their sales go before they expand, then we'll frustratingly probably find that we've got to wait before it comes over here. Thankfully, once something's got approval in the FDA or through the European Medicines Agency, there is sort of a fast track. They don't have to go through all quite the same hurdles as though it's come from nowhere. So that should make it a little bit quicker. And we did see this happening relatively speedily in regulatory terms in the case of Neffy.
And in your clinics, Adam, how have you found the news of Neffy going down? Do your patients, are they more of them wanting to turn to Neffy, or are more of them wanting to stick with their current devices?
The first person I asked was my niece, who has food allergies and carries a Jext. And I said to her, "Oh, I said, I've got some good news for you. In a few months' time, you're going to be able to have a nasal spray instead of your Jext." And she pulled her face and said, "I'm not sticking anything up my nose." So and that was sort of like when it sort of dawned on me that this isn't going to be a
Yeah.
sort of wholesale change. Everybody's different,
Mm.
and this is before we've had even the beginnings of the sensible conversation about other issues. It's literally just, I don't want to stick anything up my nose, and some people don't. So for people, there's people that don't like needles, there's people who don't like things up their nose. So yes, we've had a lot of very positive noises. I've had a lot of families where, especially the ones where actually a lot of the anxiety about their food allergy is the anxiety of having to use a needle. For
Mm.
them, it's going to be a quicker and easier decision, and they're there waiting with open arms to take this. But it still needs that conversation. They still need to know how to use it and when to use it, and make sure they understand that this is a newer device that doesn't quite have that same heritage that the other devices do. Whereas for others, there's ones that say, yeah, that might be good. So there's going to be, I guess the thing that, worries allergists is, goodness, we struggle enough to get the patients that we need to have the conversations in the time that we're allocated them. And this is going to be
Mm.
something else. So I'm hoping, and certainly I'll be making a lot of noise about trying to get some really good written information out to patients so that they have as good an understanding as possible about what's involved in making this decision before they then, and I'm not saying they absolutely have to have the conversation with their allergist, because everybody is different. But, I really hope that we get good material out there so that people really understand what any decision should be based on.
Mm. We've had a few people who have said they are interested in Neffy, but they'd like to hang on to their adrenaline injectors.
Yeah.
And
Yeah.
I'm just wondering, would there be a situation where someone might be prescribed one adrenaline injector and one Neffy device?
Yeah, I mean, I'd never say never. I mean, I think that's probably, people will feel that that's, going back to what we've talked about in the past about trying to keep things as simple as possible. Having two devices that work differently is adding another layer of complication, not just for yourself, but, if somebody else needs to administer it. And I think, one of the other things we've not really touched on this is that, it's all very well having the new fancy device, but if no one else knows how to use it yet, and there's a chance that it's going to be somebody else who's going to look at it and go, well, I knew how to use an EpiPen, but I've no idea what this even is. Then, how sensible is it to be carrying that new device? We've got to be putting all of that into the mix before we make decisions. So yes, I suspect there'll be scenarios where people will end up, and if you don't support them doing that, they'll find a way. I've got plenty of patients I know who they'll be off to see a different doctor and get Neffys from them and get their EpiPens from me if I've said to them, no, I'm only giving you one because
Mm.
I think it's the best way of doing things. It needs to be a conversation, and I suspect sometimes for a whole range of different situations, it might turn out that that's the right thing to be doing.
And
Yeah,
you'll
so
need to carry two Neffy around as well. So if
Yeah.
you've got one Neffy and one adrenaline pen, one might think, well, I'll take the Neffy pen out with me out and about, but I'll use the other one at home you've still
Yeah.
got to have two of both.
Yeah, absolutely. And then you'll get, again, this is, you start getting into all sort of complexities that aren't helpful. We really want this to be as simple as possible.
mm.
Yes.
So, my intuitive preference would be go one way or the other and have a reason to do that. But as I
Mm.
said, I've no doubt there'll be circumstances where,
Sure.
and I suspect it will be more carrying two of both rather than um, rather than one of each.
Yeah, so it really just depends on the family or on the person with the allergy, and that will be for them to have a discussion about. And really, we don't know when it's going to be available for everyone, especially through the NHS. But realistically, it's going to take some time for that all to
Yeah.
flush out, and for primary care to have that training or be told about it. As
Yeah.
you said, many of them might not even know that it's been approved yet. I just wanted to ask, are there any concerns around people perhaps using it too early with symptoms that,
Um, No, not really. We know, if you give yourself a slug of adrenaline when you're minding your own business doing nothing, it will put your heart rate up and you might get a headache, but it's not going to do you any harm. So no, I mean, I would be very nervous of a message going out that sort of says, be careful not to use this too early because, that's going to stop people from using it when what would actually be the right time to use it. The only issue would be that they'll be getting through them very quickly.
And are there any ongoing studies at the minute looking at Neffy in the real world? Are there clinics using it for like oral food challenges just to get some more data on it?
So, it's worth mentioning that virtually all of the data that led to the license of this stuff were related to healthy individuals having it squirted up their nose or injected in their legs and then measuring to see that it was similar. There's limited data relating to the use of this in real patients with anaphylaxis. And there are certainly plans, and I've heard from both the UK and elsewhere, of looking to sort of, as this now is available in clinics, to start using it as a where if you're having a food challenge, for example, in a safe setting, you might get randomized to either have a Neffy or an intramuscular injection, and then seeing how quickly you get better. And if that's done at scale over a range of different departments, we might come up with some useful data that says, well, actually, in 9 out of 10 cases, response was quicker in this one rather than the other one. So I think there'll be a lot of interest in doing that. And I suspect that we'll start seeing those studies emerging now that the stuff is available.
Amazing. That's great. Thank you so much, Adam. That's been a really helpful and informative episode. And I know our community will be really pleased to have an episode all about adrenaline and the new Neffy device. So yeah, it's been a pleasure having you on the podcast, and we hope to have you back again soon.
Thanks for having me.
We hope you enjoyed tuning in to today's podcast on this very important topic. To make sure you don't miss any episodes, you can subscribe to our podcast on your favourite podcast app, including Spotify and Apple Music. Finally, be sure to follow us on social media at Anaphylaxis UK to join in the conversation, and let us know if there are any questions you would like us to answer next time.